Talking on Denosumab and GCT of the bone, not going to touch the tendon sheath. And this is one thing which has changed probably in the last decade regarding giant cell tumors. So Denosumab was FDA approved in 2013 for use for giant cell tumor of bone, and since then we are going through a phase of evolution on understanding where it can be used in the most judicious way. So when we get a patient of giant cell tumor who has a radiograph which is looking like this, there's always a challenge on how to go about it and what's the best way out. The standard of care for giant cell tumor even today remains curettage and an adjuvant, which could be either cement or bone graft. But then when you look at such x-rays, it's a dilemma whether you can do an extended curettage without compromising the joint. And you always hope that you get patients who are like this. So this is what Denosumab has done. Zoledronic acid was also doing a similar act. However, probably Denosumab has done it in a more efficacious way. So on the right is what normally comes, and on the left is what we dream to have, so that we can address whether by curettage or by resection. If you search today regarding Denosumab, this graph shows, this is a bibliometric study of 2023, and it shows you the amazing rise in the number of publications which are coming in regarding the use in giant cell tumor. And this happens with any new modality which comes in. And what it concludes is that further research is required to analyze Denosumab's safety and efficacy and understand its local recurrence of giant cell tumor of bone to identify the optimal dose. So these three things, safety, efficacy, and optimal dose, are still not decided. And the future development trends mainly focus on prognosticating markers, because the problem with giant cell tumor remains recurrence for a long time now. So talking on this drug, I think we should look at some basics. The mechanism of action: Denosumab targets and binds with high affinity and specificity to the rank ligand. Prevention of rank ligand interaction inhibits osteoclast formation, function, and survival. So this is what inhibits the osteolytic phenomena which happens in a giant cell tumor, and that is the mechanism of action. It's an injection which is given subcutaneous. For giant cell tumor, it is recommended 120 milligrams, and it is now available, manufactured in India by multiple manufacturers, and the cost is falling by the day. The other therapeutic indications have been most popular now is on in osteoporosis, especially when you have a renal compromised patient. So the good thing about it is that you don't have to do any dose adjustment. Although giant cell tumors won't happen in this age, you don't need dose adjustments with renal impairment patients. You can have giant cell tumor patients with renal impairment. However, the pediatric application is not recommended as of now. There are papers where people have used Denosumab in adolescent and pediatric age group under the cover of research protocols. It is still not recommended for pregnancy and lactating females. Special warnings: it has complications. Derangement in the calcium metabolism is always associated, especially when the patients are on steroids along with. There is a possibility of skin infections in these, because the rank ligand interaction which is happening also happens on the normal cells of the body. So it has some implication on the B and T cells immunity, and that could be one of the causes for rise of skin infections. Osteonecrosis of the jaw, this would come in when you're using this drug for a longer period as a definitive period for giant cell tumors, which are in an area where they are probably unresectable. So let's look at this diagram. It talks about the mechanism again. So the tumor cells produce factors that stimulate osteoblasts to secrete rank ligand. So this normally happens, but it increases when there is a tumor cell over there. And the osteoblasts produce a decoy receptor that normally binds excess rank ligand. So this is a normal mechanism of the bone which is there. The rank ligand binds to the rank receptor on both precursor cells and mature osteoclasts, increasing the formation, function, and survival of osteoclasts and bone resorption. So this is where the problem is happening, and our drug is going to stop this interaction and decrease. So looking at this chart, you can understand that this drug is doing nothing to the tumor cells. Giant cell tumor has three types of cells: the stromal cells, the monocytes, and the giant cells. So this drug is doing actually nothing to the stromal cells. That is where the knowledge has come in, that once you stop this drug, there is a possibility of the tumor going to come back, because nothing has been done to the stromal cells and the monocytes. So denosumab comes in the way of activation and functioning of the end product of this tumor, which is a multinucleated giant cell. So let's look at some papers which is giving us some evidence in the last few years. I'll try and take only recent papers of 22 and 23. So this is one review which talks about denosumab, multidisciplinary medical management, and they have suggested that surgery is the gold standard, and denosumab is relevant therapy option for advanced giant cell tumors. So similarly for spine tumors, which come in the category of non-resectable at times, it does has a equally effective to selective embolization. Radiotherapy actually is now going away, although this is a 2022 review. Study on imaging, it does help in reducing the blood supply. That is where the surgeons become more comfortable dissecting. However, these two slides will tell you that there is an issue associated. You can have secondary sarcomas developing. We really don't know, because of denosumab or something else going on, the interference of rank ligand because of this drug, and also higher recurrence rates, specifically when they are going to be managed by curettage. So there is an alarm which has been raised regarding the use of this. Dose and duration, as I have told you, it is still not established. Various protocols are being used still, and it is being compared with zoledronic acid, and probably the mechanism of action is different. So probably it has a role in pre-surgical patients where you are going to resect them. So I would conclude here by just summarizing my practice today. Not used in cases managed by curettage, not given post-operatively to prevent recurrence, but it is used when I'm going to resect a giant cell tumor to downsize it, or say make the surgery more easy, less vascular and more contained. 3 doses at an interval of 10 days, 120 milligrams subcutaneous. Always supplement with calcium and vitamin D, and I can tell you the cost is coming down. The single injection now is available between 8 and 10,000. Thank you very much.